Thank you. Good afternoon, and thank you for having me here. A couple of quick disclaimers before I start. First of all, I'm on Eastern Time, and I've worked in manufacturing for the last 32 years, so I'm usually more effective in the morning, so I'll try to be as effective as possible at this late hour. And then the second disclaimer is that I'm going to talk a little bit about the perspective of a private payer, but a lot of these are sort of my beliefs and my philosophies, and they remain that way until they become part of our benefit plan. So I have to say that some of this stuff may not be the position of Magna International. Okay, so we're going to take a very quick look at Magna International. Some of you may have heard the name. You may know a little bit about us. I'm going to just give you a real brief 45 seconds to a minute. I'm going to talk about some of the current employer prescription drug challenges of what an employer or a private payer sees as some of those challenges. I'm going to talk about current prescription drug benefit structure for a private payer. A little bit about U.S. and Canadian plans, because we do work on both sides of the border, and my team actually has responsibility out of Toronto for the U.S., and we're pretty much the same size on both sides, 17,000 employees, give or take, in Canada and the U.S., so there's some key differences. And also, I think something I really want to highlight as a key focus is the role of the pharmacy benefit manager between Canada and the U.S. Those are very significant differences, and I think if there's one opportunity to look at, it might be in the role of the PBM and what pharmacists actually play within the PBM. And then future Canadian RX benefit considerations of what plan design considerations are some Canadian private payers looking at. And then finally, I'll talk a little bit about what some alternatives might be to the challenges. We are a global company. We have about 117,000 employees globally. We're in currently 27 countries, and 2011 sales were $28.7 billion. We are a Canadian company founded in Canada, and a very, very good success story and growing rapidly. Global capacity, we make, in a nutshell, everything on a car but tires, and we supply every single OEM original equipment manufacturer in the world. So we're very diverse. Okay, a little bit about the challenges that we see. And as I mentioned, some of these are real and some of them are my perspective. Increasing prescription drug benefit cost versus a competitive prescription drug benefit plan, trying to keep those two things in balance, stay competitive with rising cost. Prescription drug adherence for chronic conditions. We are very concerned about that, and that has been mentioned earlier today about folks staying adherent to their medication and the cost of not staying adherent. You might ask, why would I be concerned about that as a private payer with a provincial health care plan? We're very concerned because of the impact it has on our productivity and our competitiveness in a global market. Limited prescription drug distribution or fulfillment currently in Canada is really retail as distribution. There's some very minor efforts at mail, and I'm going to talk about that I think that's a challenge. Lack of employer negotiating power. We are a payer, we're a private plan, but we really have no negotiating power whatsoever. We get a bill, we pay it. Limited prescription benefit manager program management, particularly in Canada. The PBMs here purely adjudicate claims, and I think they can do so much more, and I'm going to talk about that. Formulary management is a challenge. We don't have a lot of say on what goes into the formulary, and I think there's some improvements can be done there. Lack of incentives in value-based prescription drug plans. Some of these concepts are from other countries, some are from the U.S., but I think there's some merit there. And then finally, there's a lack of full price, I should say, cost transparency. We really don't know the full cost from the minute that particular raw ingredient is a flower in the rainforest until it becomes a pill on the market. That's really new to us as we manage cost effectively in our business model of not knowing what something costs and how to negotiate and better manage that. A little bit on drug plan design. This is how we're currently structured in Canada. For reimbursement, we have two tiers. We have a 90% reimbursement following the Ontario drug formulary, and then we have an 80% reimbursement for everything that's outside of the Ontario formulary. We do not have a deductible currently. We do cap our dispensing fee for our plan members at $8, so that drives a little bit of consumerism for them to shop around. We have a mandatory generic substitution clause right now within our plan design. We have sort of carved out and capped some particular categories of prescriptions, such as smoking, weight loss, fertility, and we do not cover erectile dysfunction. Purely consider that lifestyle, although I've been in a lot of union negotiations where they don't think so. More on that in the after party. I should say the reception. Some of the key practices between Magna US and Magna Canada. Pricing is really on a markup type model. In the US, it's really a discount model. Generic pricing, we've talked enough about that. I don't want to start another long discussion, but in the US, it's very, very low, and these numbers are relative to what we see in cost. Our cost for our Canadian plan is about 117% higher generic pricing than our generic pricing for our US plan. Brand pricing, again, is not regulated in the US, so it's much lower here because it is regulated. The professional allowance or drug rebates, in the US, those are negotiated and shared. And we actually, for a $22 million drug spend in the US, we recoup $4 million in rebates on brand drugs. Here, they are retained. Average dispensing fees are about $1.25 for us in the US, and here they're $9.70. I mentioned we cap at $8, so our plan members are taking the other $1.70 on average out of their own pocket. Generic dispensing rates, 86% for our plan in the US, and even though we have mandatory generic substitution, we're only getting 36% here in Canada. Part of that is drug mix, and part of that is prescribing practices, ways around it, in other words. And then the generic spend for us, as a percentage of our total prescription drug spend, in Canada it's 28%, in the US it's 15%, and a lot of that has purely to do with pricing, higher pricing. Mail order pharmacy utilization, this is a huge difference in the US as far as distribution, especially primarily for chronic condition management. 61% of all of our prescriptions in the US go through mail order. Here, we have less than 1%, if that, and those are filled currently at retail pharmacy, if I could even call them mail order. So, some of the PBM practices, the pharmacy benefit manager practices in the US versus Canada. In the US, yes, they adjudicate claims, of course. They do a lot of safety checks and drug utilization review, all levels of drug utilization review, quantity reviews, et cetera. The PBM actually negotiates price and rebates with pharma on our behalf. They negotiate preferred pricing with retail pharmacies. Also manage multiple distribution channels. So the PBM actually manages on the US side all of the distribution, the retail relationships, the mail order operation, which typically they own, and drive most of the fulfillment through there is generic drugs. And then specialty. Specialty or biologic is actually a separate distribution channel that's growing in the US with actual specialty biologic pharmacies to get better clinical management and better pricing, which is a very unique thing. And then clinical programs is a very key element where they actually, the PBM creates and manages key clinical programs, and there is price transparency or cost transparency in the US. Quickly in Canada, I mentioned that they adjudicate claims, but the other key differentiator is the PBM, and there aren't that many of them, it's a consolidated market, they actually contract with the large insurers, and the insurer has a contract for their entire book of business, and like I said, we get a bill. Some price negotiation, we don't see it, but I suppose it goes on. There's limited dollar transparency, limited distribution, as I mentioned already. There's limited clinical programs, although they're coming. I see some kinds of step therapy and some quantity reviews. And then there's very limited drug utilization review. Future Canada potential plan design considerations. I think annual pocket out of maximums are not out of the question. We've been looking at them, of capping what might be for a particular plan member. Annual deductibles, we currently don't have one, but that might be something we may have to look at. Special tier for biologic-type drugs or specialty drugs. This is, of course, contingent on whether or not it can be set up and adjudicated appropriately by the PBM. And then pre-authorization for certain drugs. Automatic substitution for generic may get us further than the mandatory generic. Expand electronic claim submission. I think this is huge. This has a huge potential. And then work with the insurance provider to create new clinical programs. These are some thoughts just to stir some thinking of what could be some alternatives to the current challenges facing a private payer. Well, I think contracting with private payers and insurers, a carve-in versus a carve-out strategy. Currently, it's carved in. We have our healthcare benefits, parameds, vision, dental, with an insurer, so the drugs are with them. We would certainly like the ability to carve drugs out with a PBM on our own and manage that benefit, because it is, for any private payer, by the way, it's 50 to 70% of their total healthcare cost, drugs. Develop and offer clinical programs for effective chronic condition management, diabetes, coronary artery disease, asthma, oncology, HIV, immunology. This is all done right now in the US and other countries, and this is a huge role PBMs could play. Robust formulary management is a key area, and then robust retail pharmacy contracting, this concept of preferred networks for what your plan members can go to. If one chain of pharmacies is ridiculously high, then you have it designed that they're not in your preferred network. There is some of this going on now. Mail order distribution, I've talked about this before, I think is huge. And then specialty biologic distribution, better data and analysis and analytics from the PBM here would be very helpful in helping private payers really set up their plan designs the right way going forward. And then regulatory reform, I just throw this out, I think full price and cost transparency and disclosure would create a more competitive market. And thank you very much for listening to me.